So here's a case which was actually a pretty frustrating embolization for me. So here's the cone beam CT, and like I said before, the best thing that I ever did was start off by just doing this cone beam CT with a flush catheter in the aorta. So I park in the aorta, sent over the pelvis. I use, as you saw, currently I have 2 rooms that I'll do these in, and they're both Phillips. And on the Phillips, I need a 13-second total. It's an 8-second spin, and then I add 5 seconds of contrast injection before I do the spin. So I do it at 4 milliliters per second. I do 4 for 52. I use full-strength contrast. I haven't tried half-strength contrast yet with this. I did try half-strength contrast in the liver, and it didn't turn out too well. So we just switched to full strength. And I've had no problems with this, and I haven't really had any problems with streak artifact either. So again, 5-second X-ray delay, 4 for 52, and it's a 8-second spin, so a total of 13 seconds. If you can do it from a propeller mode, you can cut that time down, but propeller mode on a prostate can be somewhat difficult because of height. So anyway, what you can see here is I've highlighted that. You'll have to just take my word for it that those both are the prostate arteries down there. Now, several slices cephalad, I didn't see a prostate artery opacified on the right. I did on the left, but not on the right. So again, incidentally, you see the corona mortis on this side. Left internal iliac artery, ipsilateral oblique. So again, reviewing things, you see umbilical, superior vesicle, prostate artery, which has that S-shaped curve, which was aptly for Schwartz. So I was kind of born to do these embolizations. And then you have your internal pudendal artery, and then your inferior gluteal artery. First I got into the VP trunk, but it went into the superior vesical artery. And you can see that it's supplying at least 2/3 and most of the bladder, which might kind of foretell us something. But you can see the reflux, because it was a common trunk with the prostate, you can see the reflux of the prostate artery. So I got into the prostate artery, did an injection. This was the early injection. This was kind of the late phase of the injection. And what you see is this pudendal collateral, which is preferentially filling on the right side. You see supply to the right prostate artery. And the catheter was kind of occlusive in the branch, and this was a 2.4, I think, that I used, and it was kind of occlusive in the branch, so all the flow was still directed away from the prostate. So unfortunately, I can't really embolize from here because I'm going to get non-target embo. I don't care so much about the right prostate because it's probably occluded on the right anyway, but it's this internal pudendal collateral that I was concerned about. So I said, okay, well, maybe I can try to get into that collateral. So here's the cone beam CT, just to kind of show you that I'm getting opacification of the left side of the prostate. I am getting some opacification of the right central gland on the far left picture. And then you can see that pudendal artery on the right. So here's a distal catheterization. It was kind of wedged in there. Did an injection, saw the same thing, but I wanted to try to possibly still embolize that distal pudendal collateral. So I did a steep oblique to kind of splay out the way things were. And as you can see, there's no way I'm getting into that pudendal artery. I mean, it's just kind of through all these tiny parenchymal collaterals. So I pulled my catheter back. I did some injections by hand just to kind of see the flow dynamics and how things would be. I was able to get some embolic in on the left side without having any reflux. I don't recall, I don't think anything got into the right. I wasn't thrilled with it. I couldn't get all that much embolic in there anyway. Went over to the right side, and what you can see here is there's proximal occlusion of the internal pudendal artery, the superior vesical artery, the prostate artery, and then on the late phase, you can see that there's segmental reconstitution of that internal pudendal from collaterals. So I did manage to get into that tiny collateral vessel just to inject it and see what was going on. And you can see these extensive tiny collaterals going to the bladder and maybe a little bit going to the prostate. And then you can see This is a oblique view, and this is the AP view. You can see there's that segmental reconstitution of the internal pudendal on the right. Can't really do anything here because if you're going to embolize here, you're going to embolize, bladder and what's left of his, segmentally reconstituted internal pudendal artery. And as you could see, he's partially supplying that from the left side. So this is kind of one of those where flow-directed doesn't work because flow-directed redistributes your flow retrograde through these collaterals, but this main artery on the left is supplying those collaterals to go to the penis. So there's not much I could really do here for him. Nonetheless, what I told him is, I said, look, I don't think this is going to work very well. There's a small chance, but we'll kind of see how it works. I'll follow you up in a month. So his initial symptoms, he was IPSS scores of 25, which is severe, and his quality of life was terrible. 1 month follow-up, his IPSS was a 10, and his quality of life was a 2. So he was pretty happy. So it actually worked. I don't think it works all that often, but it can work with a unilateral embolization. Okay, so here's another case. Is a 77-year-old with BPH and LUTS. So let's go through his list. He's got chronic AFib on Coumadin. His EF is 19. He's got 3 MIs with ischemic heart disease. He's got an ICD, type 2 diabetes, hypercholesterolemia. He's got a right BKA from an old staph infection, and stage 3 chronic kidney disease. Guess where this referral came from? Yeah, urology. So on consult, his IPSS score wasn't terrible. An 8 isn't that bad. But he seemed to be, I think it was his frequency that was really bad. He just was very, very bothered by this, and his quality of life was really bad. And urology was willing to do a TURP had he not had all those comorbidities. So, maybe I shouldn't have gone forward with this, but we went forward with it. Here's a picture of the left prostate artery. I went in with a 2-4 prograde. The left half of the prostate, you can see there's some cross collaterals to the right side. And I was able to embolize here to stasis, but only a minimal amount reached the right side. So I wasn't really thrilled with how this embolization was going to go. I went to the right side, and what you can see here is I don't see a prostate artery. It's missing. There's no supply from elsewhere. His internal pudendal artery is not there, so that's occluded. So, one of the things I would look for would be this distal IPA origin of the prostate artery, but it's not there. So this guy, okay, so we did a limited embolization, but did it work? Well, no. He came in, his initial IPSS was 8. He was unhappy. Then I made him worse. So he decided that, I think it was, I can't remember what the second one is, but anyway, he decided that he wasn't better, he was actually worse. So he went up to an 11. He was still unhappy. This guy was actually, he's a really easygoing guy. He's a nice guy. He was very bothered by his symptoms. He wanted to do something. So I brought up doing a repeat angiogram to kind of search for any other supply. Maybe there was something I missed. He insisted that we try. So I did a second attempt. The repeat angiogram still didn't show any additional supply on the right. I went on the left again and went into the prostate artery that I was in. There was just a much more rich network of collaterals supplying that right side now. You can also see arteries that are going down to the obturator on both sides. So was able to do more embolization here. But I think this is also a learning point, because this is a little bit earlier on, is this supply you would expect to be from a distal IPA, just the way it looks on the right side. But there wasn't an IPA. The internal pudendal was occluded on the right side. But I think what happened on this one is this ended up getting reconstituted from the obturator on the right. And I just think that we maybe didn't investigate or go out too far in the obturator to kind of see what those collaterals would be. So we were able to actually embolize him pretty well on this. And then 1 month after his second PAE, so his initial symptoms were 11, which was worse. And then 1 month after this, his IPSS went down to a 4, and he was pleased. He was very happy with it. Incidentally, this is also, I posted this guy on Twitter a while ago. You know, he had that BKA due to a staph infection. So he had a prosthetic limb, and he's the first guy that ever asked me to take his leg off in the middle of a procedure because it was bothering him. So he took his leg off and hung it up on the wall. Anyway, so that was a 1-month follow-up. He was pleased. At 4 months after his second PAE, he ended up having an IPSS at 2. So now we're talking about you know, a 9-point drop, and his quality of life, he was delighted, super happy. And I was actually ready to give up on him, but he actually convinced me to go in for a second round and try something else.